Hello, good afternoon, everybody. Welcome to our Antibiotic Stewardship Echo Clinic for today. Thanks for joining us. Back here in the corner, we'll do introductions real quick. Troy Jorgensen, Program Manager, Project Echo Nevada.
I'm Amy Smith. I am the Program Assistant for Project Echo.
Charlie Krasner, I work for the VA and the university.
I'm Jessica Thompson. I'm an infectious diseases pharmacist at Renown.
I'm Esther Zhang. I'm the infectious diseases pharmacy resident.
All right. And then we'll go around the audience here. So I think Mount Grant, is that Toby? Are you there?
I am. Can you hear me?
Yep.
Far out. How y'all doing?
Good.
Great,
Good
thank
to
you.
hear you today.
Good deal.
Thanks for being here. Do you have any cases you want to talk about today?
No.
All right. Feel free to chime in if anything comes to mind, though.
Hey, I'll break in if I have a question. Thank you.
Camera was 20.
Thank you.
Oh, yeah.
Carrie Jo, go ahead. Looks like you just took a big sorry about that.
Yeah, eating lunch, sorry. I'm here.
What's on the menu?
It's so good I can't talk.
And just remind us real quick where you work.
Oh, sorry, VA Reno. I work with Beth Wilmer in infection control.
Excellent, thank you. Somebody joined by their iPhone. Could you introduce yourself?
That's Beth Wilmer, VA Reno.
Hi, Beth, thanks. Kristen Carmen from South Lyon. Could you introduce yourself?
Hi, I'm Kristen Carmen from South Lyon Medical Center, infection control.
Thanks, Kristen. Do you have any cases or anything you want to talk about with the team today?
I don't have any cases today. I'm sorry.
No problem, thank you. Joy Greenhall, Joy, just make sure you click the audio icon, the join audio icon in the lower left corner of the Zoom window, and we should be able to hear you if you have a microphone. So we'll move on here. Oh, Jesse Murray just popped up on my screen. Jesse, could you introduce yourself?
Hi there, I'm Jesse Murray from Boulder City Hospital.
Hi.
Thanks, Jesse. How great was my presentation yesterday? A. Lissar, are you there? Do we have a microphone for you? Washoe County Health District. Great, thank you. William Schultens, I think it is. Could you introduce yourself? Willem, are you there? Could you unmute yourself? All right, couple more here. Shauna just wrote in. Shauna Pollock from Infection Prevention at Renown. Thanks, Shauna. Lisa Schaefer from Mountain View Hospital. Thanks, Lisa. Good to have you back today. And then Darren Coons. Darren, could you introduce yourself? All right, maybe no microphone there, but I believe you're a pharmacist.
This is Willem Schultens. I finally unmuted.
Okay.
I will.
Hospital.
Great. Thanks, Willem. Good to have you today. And then Darren, if you could write in, I think you're a pharmacist at William B. Ryrie Hospital. Is that correct? Thanks, Darren. Good to have you today. So we'll open it up. Does anybody have any specific patients they want to talk about or general questions about antibiotic use? Feel free to unmute yourself or write in through the chat box.
I'm going to talk about maybe the peripheral line. If anybody's seeing peripheral line infections. Okay. We don't have anything specific, but we've noticed over the last couple of weeks a couple of patients that have had peripheral line infections that have resulted in bacteremias. And we were just curious if anybody else is seeing that and to see what your policy is also on removing peripheral lines. Do you have a set number of days before it's removed, or is it based just on how it, the functionality and if it looks okay?
Jessica, this is Beth at the VA. And so question for you when you said that, do you have the change as indicated policy, or do you still guys do a 96 hours or something like that?
Changes if indicated.
Okay.
And Shauna, correct me if I'm wrong, but I'm pretty sure that's what it is.
Okay. We do change as indicated here also. The question on that is, you got to be really tight on symptoms and things because change is indicated. So are you going to sit and wait until you get an infection because then now it's indicated to change it?
Mm-hmm.
It's a tough one, but we do CHG peripheral dressings on our PIVs, so we're trying to do everything we can to prevent the. I must say, over the years, some of the worst infections I've had have been related to PIVs, not central lines. So I'm, it does make me a little leery of going as indicated, pushing them out. But we did do that, and we did not see an increase of PIV infections. So
Do you monitor those? Because they're not reportable, right?
they're not reportable. The only way I monitor them is if they come back to the ED with a superficial infection or bacteremia, and if they have positive blood cultures, because we get all of those, or if somebody on the floor tells me. They're very difficult to find because we have so many PIVs. It's a tough one to find. So unless they're cultured or somebody lets me know, they're hard to monitor.
Awesome. Thank you, Beth.
Yeah, these two patients, I mean, they were in for relatively minor things, and both of them ended up with bacteremia, septic phlebitis, and bought themselves 2 to 4 weeks of intravenous antibiotics in a nursing home. So it was a massive, setback for the patient and extreme cost, and really unfortunate. And those were just two we happened to pick up, so we don't know that maybe more going on, but it's not good. All right. So today I'm going to talk a little about, beat a dead horse, a little bit about some more C. diff stuff that's come out, one little fun story, and then Jessica is going to talk about some more evidence. Again, we've been really emphasizing where shorter is better, and she's going to talk about an interesting new study that just came out. So before we go on, anybody, go to the first one. What's the little doggy eating?
Pig ear.
Looks like a pig ear.
Yeah.
Is that your dog?
No, that's a gross dog. I have a cute dog. Anyways, I'll show her a picture next time. So, next slide, please. All right. So this just came out this week. There was a multi-state outbreak of salmonella, and it was in many states, so far not in Nevada, and it turned out there was a place called Pet Supply Plus. They were selling bulk barrels of pig ears, and when they did a exposure, epidemiologic exposure, it turned out of the 45 people who got salmonella, 34 of the 38 patients that they were actually ill reported contact with a dog before getting sick. And so they found out that these pig ears that are for sale were contaminated with salmonella, and it was across the country. And so their recommendation is do not feed recalled pig ears to your dog. Even if some of the recalled pig ears were fed to your dog and no one got sick, do not continue to feed them to your dog. All right? This is very basic.
That's your public service announcement for the day.
So anyways, if you do see salmonella in a patient, could be from chicken and stuff like that, but ask them if they feed pig ears to their dogs. Right.
But even if the contaminated pig ears were recalled, if they were touching a barrel with all the rest of the pig ear batches, then it would just continue to spread.
Yes, that's why it says wash containers, shelves, and areas that held the recalled pig ear dog treats with hot soapy water. Certainly it could spread very easily, and maybe just touching it, then could touch something else, could have been exposed to it.
Thanks for the comment, Kristen.
Yes, it's very contagious. All right. So this is, you may have heard my talk about 2 or 3 months ago. I was talking about probiotics, and that probiotics mean it's something beneficial, and I was saying that probiotics is really, it's like making something which it's not. It's just curdled milk in a capsule, I call it. But and so there was a lot. I talked about that. There was really no evidence that probiotics help or prevent or improve the speed up the cure from C. diff. And so after I gave that talk, this is a study that came out. It was very interesting. It's called predictors of C. difficile recurrence. So if somebody's got an episode, he recurs across a national cohort of veterans in outpatient, acute, and long-term care facilities. And so this was a case control study done at the VA, and they wanted to find out identify risk factors for first recurrence. What could they say was a predictor of somebody may relapse after being treated appropriately for C. diff? So they looked at within 30 days after end of C. diff infection treatment. So they took 974 cases, and for each one case, they compared it to 4 other cases that did not have it to see if they can identify independent risk factors for relapse. And so they had the usual suspects that we all know about. Antibiotics before, during, and after treatment were strong predictors, and they alter the recovering colonic microbiota, allow C. diff to proliferate, and allow C. diff to recur. And obviously, we've talked about it, the fluoroquinolones are by far the highest risk of all antibiotics for causing a relapse of C. diff. Then they talked about immunocompromised patients, people on steroids, cancer patients, older patients. They also increase the risk because they have difficulty making antibody response to the C. diff. And one that's increasingly evident is PPI use. You don't have any acid in your stomach, so the spores are able to germinate and activate the C. diff. So those are the standard ones we all know about. But what they found was something surprising. It wasn't surprising if you heard my talk, but they found that taking probiotics, one, increased the risk of getting C. diff 4.6 times fold. And if they did get C. diff and it was continued, it continued 2.3 time risk for relapse if used during or after C. diff infection. So probiotics were actually a risk factor for C. diff and a risk factor for the development of C. diff. And I was going to show you the slides I showed my last talk. Basically, this was a study that was done, and what they wanted to do is they wanted to wipe out people's gut flora, healthy volunteers, and see what improved the chances of getting back to normal microbiome and what delayed it. And so they took 21 healthy volunteers, healthy people. They gave each one of these people ciprofloxacin and Flagyl, guaranteed to wipe out the gut flora. So basically they had like a sterile gut flora. And of these 21, they divided each 7 into each group. So one group, they were given a probiotic supplement, which they describe as lactobacillus, the usual things that you see in like Lactinex and stuff. So the gut was wiped out. They got twice a day probiotic supplement, Lactinex, for 4 weeks. The second group of 7 people, they had actually stored their stool before this antibiotic course, and they just replaced their stool to repopulate the intestines. And the third was no intervention. Some of these people, they just said, let's see what happens. So which group recovered their healthy microbiome the quickest? Which ones would you think? The patients given probiotics, patients got their old stool, or got no intervention?
Number 2.
Yes, obviously, it's like a stool transplant. It is a stool transplant. It's your own stool. Immediately, your microbiome is very healthy. Which group took the longest by a long shot to recover, and why? The probiotic group or the no intervention group?
Probiotic group.
Oh, somebody was actually
We've heard it
listening. Very good. So I'll show you why. So that was correct. So the stool transplant immediately had a healthy microbiome. The no intervention took a few weeks to months, but actually got back to baseline. But the probiotic supplement, even after 6 months when the study ended, did not have a healthy microbiome. So next slide. So that's what I say. The watchful waiting group had recovered their microbiome, but at a slower pace than the stool transplant. But the probiotic group took far longer to return to a normal fecal microbiome than the other 2 groups. Even after 6 months, they still do not have a healthy microbiome. So next slide. And so this is basically, if you look at this here, so this is the stool of on the left you have probiotics. The probiotics are those green tablets. So if you look at the stool, the probiotics grow in the intestines and they block the healthy bacteria. So obviously there's a lot of probiotics, lactobacillus and other things. The ones in the middle, the auto-fecal microbiome transplant, you see a nice, all different colors, very healthy microbiome. On the right, the spontaneous recovery, you still see some healthy bacteria, but not as healthy as the auto transplant. So what you've seen is that when you take a probiotic, particularly if you've just been treated for C. diff, the probiotic repopulates the intestines, but it's not a healthy bowel. It's just a few bacteria that are given. Don't allow the healthy bacteria to get in there, because in a healthy person you may have 300-400 different species of bacteria that are all working together, and they're blocking the C. diff from recovering. So this is very interesting. This was the study, and this was shown in the VA study. Giving people probiotics before, during, or after blocks the ability of the healthy intestines to repopulate and puts them at a much greater risk for C. diff relapse. So I also presented a case from Scripps in San Diego where they looked at this and they found these same results, and they actually took Lactinex or any probiotics off their formulary. So that's just was interesting, but this was the experiment and was at least shown among the VA to play out. Next. So I also talked about last week about there was the FDA came out, this is an article, fecal transplant is linked to a patient's death, the FDA warns. And what happened was 2 patients who had gotten stool transplants, both of them developed ESBL bacteremia, E. coli bacteremia, and one of them died after the stool transplant. And so they actually stopped all research at that point by the government. But then Open Biome, which is the nonprofit group that most hospitals use, they said that we are actually screening very carefully for every kind of resistance from VRE, ESBL, CRE, HIV. So they only accept about 1 out of every 30 patients who try to donate their stool. And so the FDA reviewed their document, and just last week came out, the FDA has approved Open Biome to continue to supply the rigorously analyzed stool samples for fecal microbiome transplants after patient deaths occurred from the non-screened stools from a different supplier. So I don't recommend going to YouTube and doing your own stool transplant guidelines. So this is good news. Open Biome's been very good. I mean, they're a nonprofit. They work for the patients, and we've had success with them. So this says that Open Biome can be used. And this is one more article. This just came out in a abstract form this week, and they say, IDSA guidelines recommend basically biocide, so biocide resistance and transmission of C. So biocides are chlorine-containing products that are supposed to kill the C. diff, but there's increasing resistance among C. diff. So biocide resistance and transmission of C. diff spores spiked onto clinical surfaces from an American healthcare facility. So the IDSA guidelines, Infectious Disease Society of America guidelines, recommend an EPA-registered sporicidal agent for environmental cleaning. And the question is that effective in eliminating spores and reducing transmission? So this study looked at whether these chlorine-releasing agents done at the indicated dose concentration actually kill the C. diff spores, because they can survive for months despite ongoing cleaning efforts. And studies have shown that, if you put a new patient into a room where somebody had C. diff previously, there's like a 2 to 3-fold increased risk that patient's going to get C. diff. So this is very important. So they studied a disinfection at a concentration of 1,000 parts per million of sodium dichloroisocyanate at a recommended 10-minute contact time to see if clean surfaces could still contribute to nosocomial transmission. So they followed the exact concentration of a FDA-approved product. They cleaned these surfaces for 10 minutes, or let it soak for 10 minutes. And then they saw whether or not things like the flooring, stainless steel, like the bedding, and isolation gowns exposed to these areas could actually still get populated by C. diff. And they tested various exposures of these things for like 10 seconds to these areas to 10 minutes. And they found within 10 seconds, even in a properly cleaned surface, you were able to easily transmit C. diff to all these spots, from like the bedding, the flooring, and isolation gowns that physicians and nurses wear. And so their conclusion was that environmental cleaning is not adequate by itself. You have to throw in hand hygiene, wiping down by hand, hard surfaces, antibiotic stewardship program, early isolation. And I know at some hospitals, like the Mayo Clinic had a recent study where they did standard cleaning, and then they alternated. They threw in UV robots that go on 10 to 25 minutes. Were able to reduce the risk of C. diff in those wards by 30 to 50%. So, just the understanding is that even if your environmental people are doing a great job, a lot of these spores are resistant to these properly applied cleaning agents. And so thinking about UV robots, they're very expensive, but they do seem to benefit reducing transmission, along with, making sure that everybody immediately gets rid of their gowns, good hand hygiene, etc. You guys have any thoughts on that, or what you guys are doing, or how you're dealing with C. diff patients?
Get that study. This is Beth at the VA. So we do use primarily bleach solution. And we do a 2-step cleaning, so they have to clean first, then disinfect, and the appropriate contact time, and we're hoping they do the right contact time. We do follow with UV light when possible, but as you know, we have a semi-private room, so it's not always feasible to use UV light. We do put all our patients that have C. diff in contact isolation, and we try to put them in private rooms. Sometimes it's not always feasible, but we do try, and also the curtains need to come down on any isolation room when they're doing a terminal clean.
I mean, this would tell you, just you can shoot those curtains are probably wall-to-wall C. diff. If you just 10-second exposure a gown.
Yeah.
What do they do with them? Do they clean them? And how do they do with those?
We have disposable curtains, so they just take them down and put up new ones.
Kristen, Jesse, or Lisa, do you have any thoughts or something you want to share about what your hospital does?
Here at Boulder City, we're very lucky that all of our rooms are private, except I think 2 on our rehab unit and 2 on our geropsych unit, maybe 3 on the geropsych unit. And like the VA, we do terminal cleaning with a bleach solution, and then obviously take the curtains down. And I've gotten them to where they actually wash the walls down. So doing our best we can with what we've got.
Best thing is just to avoid getting C. diff in the first place by not giving them probiotics and using short course antibiotics. So this is a segue into Jessica.
So Lisa shared, we have very few semi-private rooms. We remove curtains, use Xenex.
That's the UV light.
Okay.
Thank you.
Yeah, thanks for that comment, Lisa. So we'll switch over to you.
I was reading that Xenex, these things don't kill Staph aureus. They're really only very good they don't kill a lot of drug-resistant bacteria.
So we've talked quite a bit about C. diff, but that's not the only side effect, if you will, of antibiotics. And this was a study that came out a couple of years ago. This is a retrospective study of any inpatient at Johns Hopkins Hospital that received an antibiotic for 24 hours or more. And what they found was that 1 in 5 patients, and they followed these patients up for 90 days after discharge, 1 in 5 patients developed some sort of antibiotic-associated adverse drug event. I think 10 of those patients were C. diff, but this could be anything from nausea, vomiting, diarrhea to something as severe as C. diff or complication of their PICC line, to name a few. So 1 in 5 patients developed an adverse drug event. It's huge when you think about how common antibiotics are in the hospital. Okay, next slide. This study was just published, I think it's actually an early release. I don't know if it's been formally published yet in the Annals of Internal Medicine. This is a retrospective cohort study of a group of hospitals in Michigan. So they looked at about 6,500 general medical patients with either community-acquired pneumonia or healthcare-associated pneumonia to look at duration of therapy and whether or not antibiotic duration was appropriate or excessive. And what they found was about 70% of antibiotic durations for these 2 indications were excessive. And what they counted as excessive was about, they looked at signs and symptoms to see if they've resolved. So a minimum of 5 days of treatment for community-acquired pneumonia and a minimum of 7 days of treatment for healthcare-associated pneumonia. And found that 70% of people, again, received antibiotic courses that exceeded those durations. They exceeded the duration by 2 days for community-acquired pneumonia and 1 day for healthcare-associated pneumonia. But the interesting thing here is that when they looked at what attributed to this excess duration, it ended up being antibiotics prescribed on discharge. About half of the total duration of therapy for these patients were prescribed on discharge. So they're getting the same length of treatment inpatient as they are outpatient. And that resulted in the majority of the excess days that they saw. And they looked at side effects as well and found that each excess day of antibiotics was associated with a 5% increase in odds of antibiotic-associated events reported by patients. Now, a lot of these were non-severe side effects, but they're side effects nonetheless. Completely unnecessary for them to have occurred, since we know very well now that 5 days is more than sufficient for community-acquired pneumonia and 7 days is more than sufficient for HCAP as well. So this was really demonstrates the importance of evaluating antibiotics on discharge from the hospital. And what we found when we did this a similar review a couple of years ago is almost the exact same thing. People are doubling the course on discharge. It's just easier than actually counting out. They've already received 3 days, let's give an additional 2. They just write for an additional 5 on discharge. So if you have the opportunity, please look and see if there's definitely some opportunity to improve prescribing on discharge. Next slide. This study was accompanied by a great editorial, and I thought it was kind of interesting, this quote. It says, "Change is scary. Medicine's a conservative profession. The core ethos of our profession is based on an oath that's 3 millennia years old. Nevertheless, to live up to the expectation that our patients have for us and that we have for one another, we must overcome inertia and tradition and change practice when compelling evidence becomes available. After dozens of randomized controlled trials and more than a decade since the initial clarion call to move to short course therapy, it is time to adapt clinical practice for diseases that have been studied and adopt the mantra, shorter is better." They go on to cite over 50 clinical trials that have shown for numerous indications that shorter is better than our traditional lengths of therapy. You don't need the football scores, if you will, of 7, 10, 14. We should be thinking 3, 5. So this was a great little editorial. I encourage you to look at it if you have time. This was another editorial. This was published a few years ago by actually the same author, and I included this in here because it talks about the durations of therapy that have been studied and found to be equivalent to the longer durations of therapy. So outcomes are the same, but as we know, for each excess day of antibiotic, we increase risk of a side effect completely unnecessarily, and can actually cause more harm than good. So we now know that for community-acquired pneumonia, we should be treating 3 to 5 days. Nosocomial pneumonia, definitely less than 8, probably 7 or less in a lot of cases. Pyelonephritis, 5 to 7 days. Intra-abdominal infection, there's some great data now that 4 is more than sufficient. Sinusitis, 5 days, not the commonly prescribed 7 to 10 that we still see. Cellulitis, especially an abscess that's been drained, we may not need any antibiotics, but 5 to 6 days. And there's even a debate now with chronic osteomyelitis, should we be treating with shorter durations? And here are a few that didn't make that chart. Acute otitis media, 5 to 7 days if it's a child older than 2. There's actually some good data for children less than 2 that you want to go a full 10 or you can increase risk of recurrence, but in the older than 2 population, 5 to 7 is more than sufficient. C. difficile, 14 no longer, we're going 10. Spontaneous bacterial peritonitis, 5 days. And the list goes on. These are the ones that have really the best evidence supporting their use and then are in guidelines now. So does anybody have any experience? Have you guys looked at if people are prescribing on antibiotics on discharge and if it's resulting in excessive durations? You might just, if you haven't, just eyeball a few charts, like eyeball a few pneumonia patients when they're discharged just to see what providers are doing. I think it's easy to turn a blind eye because we're so focused on our wheelhouse. I mean, I'm definitely guilty of this. Like, my job is appropriate antibiotic use in the hospital. So why do I care if they're discharged on an antibiotic? And we should care for the community, but also these patients will come back more often than we realize.
I get calls from outside physicians, and probably the most common thing is you'll see in a community hospital is like an E. coli pyelonephritis with bacteremia. The two misunderstandings is one, that it has to be IV. If you get an oral agent, a quinolone, or a Bactrim, or even an oral cephalosporin, you can switch as soon as they're stable. And the other thing is they assume that they need 14 days of treatment, okay? For an uncomplicated pylobacteremia, 7 days is all it takes. And so gets people out of the hospital quicker. And a lot of our patients, you know, are older people that we're sending to a nursing home. You don't want to give them 14 days of Rocephin, going to a C. diff pit, and then they come back 2 weeks later with a fulminant C. diff and die. So I would say that's probably the most common thing that I see. Just because it's bacteremia, but the only thing that really needs IV therapy would be a staph bacteremia. Okay, but almost everything else, and that's that whole move we talked previously about, 6 weeks for osteomyelitis, cephalosporin, cefazolin. You just get like a osteo, you debride it, 3 or 4 days of IV therapy, get the culture results, and switch them to oral. So, and some of the orals like Bactrim really don't cause C. diff, so you have a lot of options. So, but I would say in your hospitals, I think the most common thing you're going to see is the E. coli bacteremias from pile and stuff. And she mentioned 4 days for intraabdominal infections. Those are things like, somebody has a diverticulitis and they drain it. If it's, obviously if it's a perforation, they're still everywhere. It's not 4 days. But when you control an infection, that's the major thing.
Even if there is gross contamination, the maximum recommendation now for those intraabdominal infections is 7 days. Yeah. Anything beyond 7 days doesn't improve the outcome. It just delays an inevitable return to surgery.
Yeah, so like acute cholecystitis with sepsis, 4 days once you get rid of that gallbladder and stuff. So at the VA, we have control of our residents, and all the attendings that are brought in, they're going to talk to us before discharge, see how long they're going to treat, okay? Because, the hospice probably can feel funny. I just want to give 1 day of an antibiotic. I'll just give them 5 or 7 just to make them feel like they're doing something. But you don't have to be back to normal to be off antibiotics, okay? And you don't have to feel completely normal. As long as you're going in the right direction, the body will take care of itself.
Beth, did you have something you want to say?
I have a question. Jessica, have you seen any studies or any guidelines to have a stopgap for that on discharge? Are there any computer programs with identifying their ICD-10 and saying, oops, they hit their quota of antibiotics?
I've not heard of that. That is a fantastic idea, but I've not heard of that. A lot of it is manual review. I think there's a role for this in medication discharge reconciliation. But again, I think it requires somebody with kind of an innate or a good understanding of how long these should be treated and how they should be treated. But I think there's some opportunity there for sure.
And Toby from Mount Grant said, some of our providers do indeed go longer, and I'll be sharing the info today at our next staff meeting. And that the visualization of a C. diff pit was just
The mosh pit. Go in there first.
And there are some requests for that slide deck. So I didn't post them on the website yet, but if you want them, go ahead and send me an email. This is Troy. I think most of you have my email, or I'll send it out through the chat right now. So I'll send you those slides if you want. Any other questions or comments out there?
All right, so stop probiotics, shorten course of antibiotics. Don't let your dog eat pig ears.
You gave me an idea though for another topic, which was, we talk so much about stopping antibiotics. We overtreat. There's one disease state that I don't think we do that with, and that's with Staph aureus bacteremia. Yeah. So it might be a nice, that people have a tendency to undertreat Staph aureus bacteremia. So that might be something to visit.
My first week of my first job, I remember the surgical team sent home a guy with Staph aureus bacteremia, and he came back on oral antibiotics, and he came back, like a week later with aortic valve endocarditis and died. So It's not a jail staff bacteremia. That might be a good topic. All right, thank you all.
Yeah, thanks everybody. So we'll be back next month. August 15th will be the date for that one. So hope to see you then. Keep thinking of your cases and those types of things though too. We want to help you with those. So if you have a case that comes up between now and then, feel free to email it to me and we'll talk about it next time. So thanks everybody.
Thank you.
Thank you.
You guys.
Thank you so much.